Hello and welcome. My name is Alice, and I'll be in the background answering any Zoom technical questions. If you experience difficulties during this session, please type your question into the Q&A field, which is located on the Zoom panel at the bottom of your screen. We encourage you to submit written questions at any time using the Q&A. Finally, during today's event, live closed captioning will be available in English and Spanish. You can find the link in the chat field. With that, I'd like to introduce Laura Miller, a medical consultant in the Division of Quality and Population Health Management.
Good morning, everybody, and welcome to our updates on HCPCS codes. Next slide, please. So I'm going to run us through the agenda. And I wanted to thank you all for joining us. We are going to be discussing the release updates to the ECM and Community Supports HCPCS guidance. And I would not have passed a quiz prior, but HCPCS does stand for Healthcare Common Procedure Coding System. So in case you're asked that at holiday trivia questions, you will win the prize. These updates have been informed by feedback the department has received from the field to streamline coding and data exchange and reduce administrative burden. I think that's one of the things that we're all super aware of is administrative burden. And we really want to minimize delayed or non-payment due to coding issues for ECM and CS. We're super happy to release these updates. We've been focused throughout 2023 on making policy refinements to both ECM and CS to increase standardizations, all with the aim of increasing number of members served. That's really what it's about, is getting care to people. And this updating of the HCPCS coding guidance has been part of those efforts. We're very grateful to stakeholders who have provided feedback about the updates that the department should consider. And we have spent a lot of time in discussions with stakeholders and internally vetting these updates. Before we dive in, we are going to cover the agenda, which you have here. So we're going to talk about the latest on ECM and Community Supports implementation. We're going to review the background on HCPCS coding guidance and the landscape of ECM and Community Supports data sharing guidance. And we're going to give an overview of updates to the ECM and Community Supports HCPCS coding guidance, and of course, Q&A at the end. So next slide. So this is an overview. I think probably most of the people in this room could recite this slide, but we'll review it just quickly. ECM and CS went live in January of 22. ECM is a Medi-Cal managed care benefit that addresses the clinical and non-clinical needs of high-needs, high-cost individuals through the coordination of services and comprehensive care management. Community supports are services that address the social drivers of health that Medi-Cal managed care plans are strongly encouraged but not required to provide as medically appropriate and cost-effective alternatives to utilization or of other services or settings, such as hospital or skilled nursing facility admissions. So again, these are, I think, two incredibly important cornerstones of CalAIM that we are all working on, and they are evolving over time, which is, I think, entirely appropriate for such an extensive undertaking. So next slide, we're going to talk a little bit about the data. So you can see on this slide, looking at numbers of members enrolled, and the department really is committed to providing transparency and reporting about these programs. You can see the total members served in ECM and Community Supports, and throughout 2023, it's continued to rise. You'll notice that these slides start at Q4 22 and then show the most recent data that we have publicly released, which is Q2 2023. And again, the curves are going up, which we are very grateful to see. We aim to release the data on implementation for Q3 2023 in the coming weeks. You can see you have a link here to the source, which is the Q2 implementation update. Next slide. So we've been really committed to engaging with stakeholders through multiple modalities. We have stakeholder advisory groups. DHCS has been engaged in a number of listening tours. Surveys have been done. Data has been submitted from MCPs, and interviews have been done. We really want to understand what's happening in the field and take that information in and iterate so that we improve. I just came from an 1.5-hour call with the Children and Youth Advisory Group, where we really heard a lot of what's going on the ground and folding that into our thinking. It's the way that we need to move forward, and we're really committed to that. One of the things that stakeholders in the market have expressed is a concern with lack of standardization and high administrative burden. So based on this feedback, the department has engaged in a broader effort to establish more standardization and reduce administrative burden for plans and providers. Again, I say this on the other call, but prior to coming to the department, I was involved in an ECM program in Alameda County, and administrative burden was a huge issue. We spent time after time trying to decrease administrative burden, make the program plan agnostic vis-a-vis our community health workers and our patients. And it's a lot of work. So it's wonderful to be at the state level, trying to really improve all of that for all of us. So as part of this effort, in April of this year, we developed new standards for data exchange between plans and community supports providers, and made updates to several of the existing ECM and CS data exchange documents. On behalf of DHCS, I really do want to thank all the stakeholders who have taken the time to engage with DHCS and provide feedback on the HCPCS Coding Guidance and other data sharing guidance made previously this year. Your feedback has been critical in helping us define the design, refine the design of these programs, and ensure that as many eligible members as possible are connected. And again, that is the direction in which we are all pulling, is connecting members to services. I'm going to pass the next set of slides to Tyler Brennan, who is our community supports guide and guru, and who also is super data man. So Tyler, take it away.
All right, thanks so much, Dr. Miller. All right, so some background on ECM and community supports data sharing. Before we get into the content today, our team did think it would be helpful to provide a brief background on data sharing for both ECM and community supports. So information sharing among managed care plans, providers, counties, community-based organizations, and DHCS is all critical to ensuring the successful implementation and adoption of ECM and community supports. And moving on to the next slide, please. We've released a number of data guidance documents over the 2 years that we've been in implementation, and we wanted to go over some of that now. So we'll provide a quick overview of the landscape of ECM and community supports data exchange guidance before we dig into the updates to the HCPCS coding guidance that we want to share with you today. At the start of the programs, DHCS developed guidance to standardize information exchange between managed care plans and ECM and community supports providers, as well as between MCPs and DHCS. Standardization is designed to promote efficiency and reduce administrative burden as much as possible. Based on feedback from the survey and other stakeholder sessions that we've had throughout 2023, DHCS has updated all of its data guidance documents. Today, we're going to focus on unveiling the updates and new codes, as well as modifiers that have been added to the ECM and community supports HCPCS coding guidance. Next slide, please. So the next 2 slides provide a reminder of the core data guidance documents that were originally published in 2021 and that we've updated in the spring of this year. So one, we've got the ECM and community supports billing and invoicing guidance. These are standard minimum necessary data elements managed care plans need to collect from ECM or community supports providers, some of whom may be unable to submit ANSI, ASC, X12N, 837P claims to their managed care plan partners. 2, we've got the ECM member level information sharing guidance. These communicate standards for the exchange of member information between managed care plans and ECM providers to initiate, support, and track the delivery of ECM. And next slide, please. We've got two more. We've got number 3. We've got ECM and Community Supports coding options. This is what we're going to be highlighting today. This guidance document contains the DHCS established HCPCS codes and modifiers that are used for both ECM and community support services. We're going to be discussing the updated guidance and codes, which is going to be the focus of our webinar today. 4, we've got the quarterly implementation monitoring report and the associated guidance, which includes the quarterly MCP reporting requirements, as well as the Excel template related to ECM and community supports implementation across multiple domains. This is supplemental to encounters, and we also did update this in April of this year. And slide 10, please. So as you recall, in addition to updating the other ECM and community supports data guidance documents earlier this year, we also released new standards for the exchange of member information between managed care plans and community supports providers. I just wanted to quickly flag the release of the updated guidance will be forthcoming shortly after we hold this webinar. And next slide, please. So looking at some of the ECM and community supports data flows, this is a slide that some of you may be familiar with, but which really sort of paints the visual picture of how data flows in these two programs. So this graphic is a visual representation of all of the data flows that support ECM and community supports programs. Each of the data guidance documents contain requirements for data exchange in different areas. So today we're going to be focusing on the exchange of service invoices and claims that must use the DHCS established HCPCS codes and modifiers. Next slide, please. An overview of this guidance. So the HCPCS Coding Guidance establishes the codes and modifiers that must be used for reporting ECM and community support services. This applies to 1, encounter data managed care plans submit to DHCS, and 2, claims and encounters that ECM and community supports providers submit to their managed care plan partners. It also applies to ECM and community supports providers that submit standardized invoices to bill for ECM and community support services that are rendered. I'm going to pass things off to Bonnie Kwok, who will walk us through the updates, at least there are some of the updates to the coding guidance. Bonnie?
Thanks, Tyler. Good morning, everyone. Excuse me, and happy holidays. I'm Bonnie Kwok, a family physician and medical consultant at DHCS in the Population Health Management Division. Please excuse the raspy voice and cough, just a little under the weather today. I was also wondering, is it HCPCS or HCPCS? Well, anyway, tomato, right? Next slide, please. I'll start off with an update that applies to both enhanced care management and community supports, and then transition to new codes specific to each program. Next slide, please. Excuse me. As you may recall, our last HCPCS Coding Guidance webinar was back in April 2023, and I shared an analogy about a HCPCS buffet, which it's not necessary to repeat here, but the same point remains. Effective immediately, plans may not require or allow ECM and community supports providers to report codes, excuse me, or modifiers for ECM or community support services beyond those included in this guidance, even if the plan and ECM or community supports provider mutually agree to the additional codes or modifiers. We heard from the field that some plans were requiring ECM community supports providers to submit non-DHCS codes or modifiers to get paid for their services. And this can lead to additional administrative burden for providers, especially those who contract with multiple plans, and may lead to issues with timely payments. Again, this update is not new and has already been communicated by DHCS, but has now been codified in the updated HCPCS Coding Guidance. We are working individually with select plans who fall into this category. And if you have any questions, please send us an email. Excuse me. Next slide, please. Now we're going to transition to specific enhanced care management updates. Next slide, please. ECM services can be delivered by a range of staff types, and this includes clinical and non-clinical staff, for which the ECM HCPCS coding list has separate codes for each staff type. Stakeholders requested more clarification on the distinction between clinical and non-clinical staff, and this newly released guidance has updated definitions for each provider type. Excuse me. I'm going to read the definitions so we're all on the same page. A clinical staff member is an individual who is qualified by licensure to perform ECM, such as LPHNs, LVNs, LCSWs, RNs, PAs, NPs, CNS, and LMFTs. A non-clinical staff member refers to anyone who does not meet the clinical definition above, and who can perform or assist in the delivery of ECM, such as MAs, CHWs, promotoras, and doulas. Please note that a clinical staff member may be certified, but this does not equate to licensure. An important point to note is that both clinical and non-clinical staff can serve as the member's ECM lead care manager, and we're tracking the provider types that are serving our members. Next slide, please. The guidance already included HCPCS code and modifier combinations for in-person and telephonic outreach by clinical and non-clinical staff. These latest updates clarify that these codes may be used to track both successful and unsuccessful outreach attempts. ECM services are defined by a combination of a HCPCS code and a modifier. For example, the code G9008 by itself does not define an ECM service. It must be reported with a modifier such as U8 to represent ECM outreach in person conducted by a clinical staff member. The GQ represents ECM outreach via telehealth. The ECM benefit is defined as including outreach, and the ECM capitation payment rate to plans includes both successful and unsuccessful outreach efforts. Next slide, please. Perhaps it's a bit unusual to have a favorite HCPCS code, but for this December HCPCS guidance update, as a primary care provider, I'm most excited about this new code, G9007, Multidisciplinary Team Conference. Based on stakeholder requests, DHCS has added this new code to indicate when a multidisciplinary team conference occurs between the member's ECM lead care manager and one or more other providers involved with managing a member's care without the presence of the member. Please note that a clinical staff member on the member's care team, as defined in this guidance, is required, excuse me, for these multidisciplinary meetings to enable sign-off and further action to enhance members' care plan goals. This code is meant to capture working time in the background that the members' care team does to move towards their care goals, coordinate or set up appointments, for example, without the presence of the member. I'm going to pass it back to Tyler to talk about the specific community supports updates.
Great, thank you, Bonnie. So we'll look at some of the codes and the updates that we have to on the community support side of things. Next slide, please. So first, we'll review a few policy clarifications across the use of the community supports HCPCS coding set. In the coding list, some community support services have more than one coding option. For example, some have different code modifier combinations for per diem and per month reimbursement. Providers should not be utilizing both codes, and DHCS has added additional clarification that managed care plans are the ones who may determine which codes to require their community supports providers to use based on their payment arrangement. Next slide, please. And one more clarification, DHCS has added clarifying guidance that the rule of eighths policy that exists elsewhere for HCPCS billing should also be applied for the community support services that allow for billing in 15-minute increments. Next slide, please. On the nursing facility transition and diversion to assisted living facilities, specifically the code H2022, we wanted to call out two small clarifying edits that we've made in the code and modifier descriptions for this code. First off, the code description has been updated to include assisted living payments. This is in response to stakeholder questions asking for clarification about the ability to use this code for assisted living facility payments for individuals who are transitioning or have been transitioned or diverted to assisted living facilities. The modifier description has also had a typo corrected to indicate the proper community support service that the code should be used for. So a few small updates, but critical ones to make there that we wanted to call out. Next slide, please. All right, and some new codes that we have that will be forthcoming, and these are specific to outreach for select housing-related community support services. So DHCS will be adding some new code and modifier combinations that must be used to track the in-person and electronic outreach efforts involved in engaging a member to initiate service delivery of the housing trio community supports. This is the housing transition navigation services, the housing deposits, as well as the housing tenancy and sustaining services. So these are new required codes that community supports providers must use to code all outreach efforts involved, both successful and unsuccessful, to engage a member to initiate the housing transition and navigation, housing deposits, and housing tenancy and sustaining community support services. Managed care plans are also required to submit the use of these codes as part of their reporting to DHCS. These codes should only be used to track efforts made to outreach and engage the member to start receiving one or more of the housing services listed above, not for ongoing outreach efforts to keep the member engaged or progress their services. Note that like ECM, these must be used for successful and unsuccessful outreach attempts. Also, please note that though DHCS is adding in these new codes for outreach efforts for these housing services, this is not a change to the existing policy that managed care plans are not required to reimburse community supports providers for outreach in order to initiate community supports. So this coding guidance does not determine the payment model between managed care plans and their community supports providers. However, managed care plans and community supports providers may work together to develop payment models that incorporate reimbursement for their outreach efforts. The purpose of these new required codes is to recognize the immense effort that it takes for community support providers to find and engage individuals who are experiencing or may be at risk of homelessness. To inform future policymaking, the department seeks to gather as much complete information as possible on the effort and time that community supports providers are spending outreaching to individuals to initiate these housing community supports. And next slide, please. So as always, DHCS will continue to consider stakeholder feedback on both ECM and community supports HCPCS codes and the guidance, and will make updates periodically moving forward. All stakeholder feedback or comments can be submitted via the ECM and community supports mailbox, and that's on screen for you here. It's CalAIM ECM ILOS at dhcs.ca.gov. And next slide, I believe I'm passing things back off to Max to facilitate the Q&A.
Thanks so much, Tyler. Max Blumenthal, manager at Medi-Cal Health. I'm part of the team supporting DHCS with some of the implementation work on ECM and community supports. We're going to start with a Q&A, and we'll open it up for questions that folks have. I see that there have been some coming in through the Q&A chat, but I think we'll start with the raise hand feature. So if you do have a question, please use the raise hand feature and we can call on you and allow you to come off mute and you can ask your question. And we'll also be taking some questions from the Q&A box if you prefer that. But let's just give folks a few seconds and we'll let folks come off of mute and raise hands.
All right, Crystal, you should now have the ability to unmute. Not hearing anything from Crystal at this time. Monica, you should now have the ability to unmute. Moving on now to Florida P. You should now have the ability to unmute. Moving on now to Seth S. You should now have the ability to unmute.
Hi, I'm just wondering, the list that you showed of clinical, I put this in the chat too, but LPTs are not listed as ECM clinical providers, but LVNs are. Is that intentional?
Hi, Seth. Thanks for your question. Yes, licensed physical therapists are not listed, and that was an intentional decision that we made at DHCS, but we are including licensed vocational nurses. And the rationale for that is that LPTs are usually, in my experience as a PCP, sign off is usually required by their the member's primary care provider. So I know that distinction is not, how do I say this? So LVNs do require like supervision by an authorized provider to sign off, but we intentionally left LPTs out given their specialization just in physical therapy, and we're keeping the list of clinical providers more broad, with, I believe, the exception of behavioral health providers like licensed family and marriage, LFMTs, licensed family marriage therapists. I hope that answers your question, but if not, please let us know and we can provide more clarification on our rationale.
I don't know if I think I still have. So the LPTs I'm referring to are licensed psychiatric technicians that.
Oh, I'm sorry. Okay.
Yes, that's okay. That work with, I work in the county jail, and we have lots of licensed psychiatric technicians, and I think we have one maybe LVN. The LPTs basically have the same, to my knowledge, have the same levels of ability. You're correct that they spend an additional 6 months spending mental health things, but in terms of licensure, I'm not sure that there's many things that the LPT can't do that an LVN does with the same sort of supervision, and that's why I'm asking, because we would potentially be using LPTs quite a bit.
Thanks for flagging that. I'm going to make a note of that. I'll bring it back to our team, and if you can just follow up, so we have your email. It will get routed to my team, and we'll respond directly to you about this. Is there, since you're you have the mic, are there any other behavioral health staff members that you have questions about besides LPTs?
No, but I appreciate your clarifying. Thank you.
Okay, thanks, Seth.
Great. Next we have Christine D. You should now be able to unmute.
Thank you. I have a concern around additional guidance around place of service codes. I understand that we don't want to restrict place of service codes, but to have guidance about when and how to use them would be appropriate, because I have some providers bill that their place of service is pharmacy when they've driven a member to the pharmacy to pick up a prescription as part of their support, right? And to me, that would be considered inappropriate as a coder. I also see some of our providers use place of service 41 because they've transported the member somewhere. And so my guidance to my providers is to use place of service 99. But there really are no specific guidelines. And I think it might be beneficial to explore some guidance around the use of place of service codes, because it does let us know a little bit more about what's happening, right?
Thank you for that question. I think it's more of a comment. Like we just to reiterate, there is not place of service coding guidance in this current HCPCS coding guidance. I think there might be a little bit in the invoicing and billing, but I think we'd be happy to take that recommendation back and appreciate your feedback.
Yeah.
Thomas K., you should now be able to unmute.
Good morning, everybody. Thank you for taking my question. So this is in regards to the new G9007 code. So just so I understand it correctly, so if our LCM is non-clinical and they're having a meeting with perhaps like the community supports team that is helping support this client, or maybe the PCP or some other support for the client that is not clinical. So would we use the code for that, or is it just for when there's a clinical team member present for that meeting?
The latter, when there is a clinical team member present at that meeting.
Okay. And then so we don't code any engagement when there's no clinical, because we have a clinical person that reviews the care plans, but they don't and we do have a clinical meeting once a week to discuss cases. But when the LCM is engaging with other supports beyond, but not including the client, there is no code for that?
Not at this time, no.
Okay, thank you.
Thank you.
Great. Up next, Yvette W., you should now be able to unmute.
Thank you so much. And I placed this question in the Q&A, so it can be disregarded now. I definitely heard on the community support side that unsuccessful outreach and engagement attempts are not reimbursable unless there's some arrangement that the provider, the CS provider, and the health plans come to. And I didn't hear if that was the same standard for ECM when that review was done of the unsuccessful attempts for ECM. So the short question is, were unsuccessful outreach and engagement attempts done when seeking to connect with someone who's eligible for ECM? Will those be reimbursed, or is that code just for tracking purposes?
Thanks, Yvette. So the code that we had on the slide captures both successful and unsuccessful outreach attempts by the ECM provider, and the capitation rate for the plans embeds the accounts for, is more accurate, the unsuccessful and successful outreach attempts. So we're using this code to track, just to get a better sense of what's happening in the field for the number of outreach attempts, both lumped together, both successful and unsuccessful.
Thank you. That is extremely helpful and answers my question beautifully. Thank you.
And I want to say, Yvette, that having done a lot of outreach in my previous role before I joined DHCS, I fully recognize the effort and time and staff capacity required to engage and conduct outreach efforts. And so at DHCS, we're really committed to recognizing these efforts and reimbursing that time and energy spent to reach our members.
Greatly appreciate that. I don't have enough words to express my appreciation for that. So thank you all so much for receiving feedback from the community, as well as for bringing your own experience into the space for consideration. So thank you.
Thank you. Thank you for your partnership.
Of course.
Okay, up next we have Maria H. You should now be able to unmute. Not hearing from Maria. I will move on now to Deepak G. You should now be able to unmute.
Yeah, hi. I have a question on G9007. I want to understand a little bit more about the intent. I understand you want to, it's useful to track, case conferences, multidisciplinary meetings, but I also want to know, is from the note-taking perspective, is it required to track who is participating in the meeting and how much time each of the participants have spent, or is it just about that meeting happened and this is the amount of time the meeting took? Thank you.
That's a great question. I'm going to share what I think, and then I'm going to ask my team to just confirm that my thoughts accurately reflect what we've provided in this guidance update. So I think that we are not requiring documentation or a list of the presence of the clinical and non-clinical staff members, that we are basing this on good faith, that there was a clinical staff member present in this multidisciplinary meeting for coding purposes. Team, can you confirm that that is accurate, that we're not requesting documentation of this?
Yeah, Bonnie, I'll jump in here. That's correct. And I think in terms of also tracking like the amount of time that is spent on these are ECM codes do not have time units associated with them in the way that they're defined in the HCPCS Coding Guidance. And the other thing, we'll just reiterate is that these HCPCS codes do not determine the payment model for ECM or community supports. And every managed care plan that the provider contracts with, you'll set up your own payment model, whether it's fee for service, whether it's some sort of PMPM. But these are the codes that must be used to track the services that are actually delivered, both for reporting to the managed care plan as well as the managed care plan reporting up to the state. So I think the answer to that is yeah, I agree with what Bonnie said, and that the tracking of time is not inherent to the design of the code, but may be based essentially on the payment model that the managed care plan sets up.
Great. Moving on now to Eileen E. You should now be able to unmute.
Thank you for taking my question. I had a question about a non-licensed person being the lead case manager or the lead ECM. How does that work when it comes to doing assessments and individualized care plans if an unlicensed person does not have that scope of being able to carry out those activities?
Thanks, Eileen. Currently, our goal here in providing more clarification on clinical and non-clinical staff is so that we can track who is actually providing the service as ECM lead care manager. And we want to know, for those who are non-clinical, you're absolutely right, there are assessments and other clinical work that needs to be done in the provision of ECM services to our members. What we've seen is for non-clinical staff, they need sign off signatures, running the care plan or assessment through their supervisory provider or someone who is overseeing their work. So technically they can still be the enhanced care management lead manager, but they would require running the care plan with someone who can be able to sign off and have the license to conduct that scope of work.
Thank you.
Thank you.
Moving on now to Noah N. You should now be able to unmute.
Hi there, thank you. I want to clarify on the G9007 for interdisciplinary case conferencing. First, just thank you so much for taking this into consideration. We definitely hear from ECM providers the need to capture services provided, care coordination activities provided when members not present. But I'm still trying to understand a little bit more when this would be used. So if the lead care manager, like was discussed earlier, is a non-licensed, non-clinical individual, and they're doing care coordination activities with folks who are non-licensed, so maybe with a homeless service provider, if I'm understanding correctly, then they would not be able to use the G9007. It would only if the case conference is with another licensed individual. Can you clarify and confirm that? And then I have another question.
Yes, yes, to clarify, the code G907 for the multidisciplinary team conference can only be used in the presence of a clinical staff member.
Got it. Thank you for clarifying that. And then the other question I had is regarding the G9008 and G9012 with the U1 and U2 modifiers for enrolled services. So this is for services after the member was already enrolled. Can you clarify if for those services, does member have to be present either physically or telephonically for the ECM provider to use those codes? Because I understood the update that for U8 modifiers outreach, it can include unsuccessful outreach, but I wanted some clarity around those U1 and U2 modifiers for enrolled services, whether or not the member needs to be present for that well.
So this is for G9008, correct, Noah?
That is correct.
Okay, so just for everyone on the call, G9008 is for enhanced care management services provided by clinical staff, and it involves the coordination care fee, physician coordinated care oversight services. The modifier is U1, and the description is used with HCPCS code G9008 to indicate ECM services. And just to make sure that I understood your question fully, you are wondering if the presence of the member is necessary in order to use this code and modifier. Is that correct?
That's correct. And the same question would apply to G9012 with a U2 modifier. Thank you. Yes, that's the question.
I believe that, yes, the member's presence must be, they must have the members present in order to bill for G9008 and G9012, which is the non-clinical staff. That's the services provided by non-clinical staff. So this would be direct outreach via in-person or by via telehealth, by video or phone or text messaging. And the caveat to that is just mass texting or mass emails would not count in this. It needs to be a direct communication to a member. Does that help, Noah?
It does. I just want to call out, then I think there still may be an opportunity to address the care coordination activities that happen outside of member being present, that cannot be captured under the G9007 because there wasn't a licensed individual present for that care coordination activity. So there still may be a gap there that we may want to look at in the future, so that we can accurately track the services that ECM providers are offering members. Thanks.
Noted. Thank you.
Up next, we have Lonnie H. You should now be able to unmute.
Hi, are you able to hear me?
Yes, we can.
I just wanted to, there was a question by Thomas in the chat that was really good. And I just wanted to ask his question and see what you guys, had to say about it. He was really asking about, is it expected that there will be reimbursement around the G9007 code? And if so, kind of how is that, being looked at? And then, if not, is it really just being used for tracking purposes?
I think I can safely say that right now we are using it for tracking purposes, but as we collect data on what's happening in the field, we use all our data sources to inform how we would develop and set reimbursement rates. So we do have frequent discussions with our healthcare financing team within DHCS on reimbursement and rates, and they have been involved in the discussion. They have been actively involved in the discussions surrounding the development of this updated HCPCS coding guidance. So I hear the message loud and clear that the services being provided or the care coordination and the time involved in having these multidisciplinary conferences without a clinical staff member should be taken into account. And I'm bringing that back to our team, and we're going to have further discussions both in the quality and population health management divisions and the MCQMD division and healthcare financing division. So fully noted, and we'll bring that back.
Thank you.
Thank you.
Great. We have Christine D. You should now be able to unmute.
Thank you. I do have another question. I would like to know about any strategies for tracking successful versus unsuccessful, but also when a member declined. Because in my mind, successful is I've reached a member, whether they're enrolled or not, right? How do we, is there a way to track that, the differences between successful and unsuccessful with the addition of a member has declined services? Like, is there any modifier we can use? Is there any diagnosis code we can use to collect that data so that we can develop payment strategies and collect data?
Yeah, thanks, Christine. We had a discussion, we've had several discussions about this particular point and internally. And all I can say right now is that at this time, we don't have further modifiers to delineate successful and unsuccessful outreach attempts. I think the main rationale is in this updated coding, HCPCS coding guidance, we're trying to capture what we heard from the field and what we deem might be the most essential at this time. And then perhaps further down the road, we would be more nuanced in breaking these codes down further or add additional modifiers. We're really balancing I think there's a fine line in trying to capture data to inform our policies and rates, and then also reduce the amount of provider burden, administrative burden in adding all these codes and modifiers. So I think that your feedback is well taken. I'm making a note of that, and we are planning to provide more opportunity for feedback in our next upcoming in our next updated HCPCS coding guidance. We don't have a set date, but the feedback that you're sharing now is valuable, and I'm taking note.
Next, we have Yvette W. You should now be able to unmute.
Thank you so much. So this is going back to Noah's question about the G9007. And I just want to make sure that I'm understanding accurately. So I clearly get that a clinical individual must be present in order for G9007 to be billed. What I wasn't clear on is, does that clinical person need to be a member of the ECM provider team? So a scenario that I can think of is that the ECM lead care manager is a community health worker who does not have one of the identified license types that were identified when defining a clinical staff who can do ECM. So the CHW, on an accompaniment to the primary care appointment, on accompaniment with the beneficiary to a mental health appointment, determined that the two systems needed to engage in some care coordination. So the CHW facilitated this MDT meeting, and present at the meeting is an LVN or an RN from the primary care, clinical person defined as a clinical person, and then an RN from the mental health space. The CHW is the only person who is associated as being a contracted ECM provider. Neither the LVN at the PCP office or the RN at the mental health provider is an ECM provider. So the only person who could be able to bill is the CHW. But the CHW is not one of those clinical types. Given that an RN and an LVN are present, can the CHW then bill G9007? Or is it that a clinical person associated with the ECM provider has to be present? That's where I got confused, because I wasn't sure if just any clinical person can be present, even though they're not going to be billing G9007, or is it that whoever is billing G9007 has to be a clinical person? Did I paint the picture? I was trying my best to paint a clear picture of a scenario that I can see really merge.
I think I understand the nuance in your question.
Okay.
You're asking who is able to bill for this G9007 code. Is it the non-clinical person who's the ECM care lead manager, or does it have to be a clinical staff member? Is that right?
Right, who is part of the ECM, who is part of the non-clinical CHW team? Because if we have a clinician who's part of this MDT that's happening in another system, if that clinician is not an ECM provider, they can't bill. So it's more so the ECM provider contracted with the MCP who has the ability to bill. If the only person representing that ECM provider in this MDP conversation is a CHW, can that CHW still bill because there were clinicians present in these other systems, the RN from the mental health system and the LVN or another RN from the primary care system?
Yes, thanks, Yvette. And I'm also looking at the time, so I'll just say this quickly. But I am under the impression, based on our guidance, that the non-clinical staff member can bill for this if a clinical staff member who's on the ECM team, given that the CHW is signing off to this RN, who is considered clinical, is present. So even though the CHW is the lead care manager, there's sign off that's needed with the member's care plan to the RN, and the RN is there, and therefore the CHW can then bill for this G9007 multidisciplinary team code. Does that help?
I think it does. It ultimately sounds that a clinical member of the ECM provider has to be present with the non-clinical member of the ECM provider, the CHW, in order for G907 to be able to be billed.
Yes.
So, okay, so it comes back to there has to be a clinical person who is part of the ECM provider who's present in this multidisciplinary team call, even though the CHW may be leading the conversation. There has to be also one of her or their clinical team members also present. Got it.
Yes. Yes.
I'm all about clean claims being submitted. Clean claims.
Yes.
No problems with reconciliation and all of that.
Let's make this as smooth as possible. I hear you, Yvette. We only have 2 minutes left, and I saw some questions that I can quickly go through before we go to the next raised hand. The main one that I saw a few were, when does this take effect? So to be clear, the first slide that I presented regarding the updates for both, the update that applies to both enhanced care management and community supports, where plans are not able to require or allow ECM and community support providers to report codes and modifiers that are not within DHCS guidance. So that is effective immediately. The other codes and updates start effective March 31st, 2024. And this guidance will be posted on the ECM Community Supports webpage after this call. I think within the next week or so, I think, to be safe. So again, that's March 31st, 2024. And for those plans who we've been individually in touch with, we are there will be additional guidance around the plans who are currently requiring or allowing these non-DHCS codes and modifiers to be used. I'm looking at the time. I'll hand it back to our Manat team. If there's anything else that I need to cover or that you saw in the questions before we wrap up.
No, I'll just say thank you so much for all the robust participation. Really great questions. And thank you so much for the DHCS team, Bonnie, Tyler, Laura, for your great responses. As Bonnie said, apart from the requirement, which has already been released about the use of the additional local codes and modifiers, the rest of these new codes will be effective March 31st, 2024. The updated guidance has not yet been released, so you haven't missed anything, but will be aimed to be posted and released in the next week or so. So thank you all for joining, and thank you so much for your questions.
Thank you.
Thanks, everyone.